Thank you for joining us for today's webinar, Pivoting from Community Practice to Academic Practice, hosted by the ACS Women in Surgery Committee. I'm excited today to welcome our moderator, Dr. Heena Santry, with us, and I will go ahead and turn the webinar over to her for introductions.
Good evening. Thank you, Jenny, for inviting me and to the Women in Surgery Committee of the college. I'm Heena Santry, and I'm currently a acute care surgeon at Kettering Health, which is a community-based health system outside of Dayton, Ohio. And I am also a design professional with a company called Arcadis, and I'm a part of the team that helps design better hospitals and plan for better health systems and integrate public health principles into community planning. So that's what I do now. But before that, I had a long history in academia. And so the tables are turned a little bit today on this webinar in that we have three amazing surgeons with us today, Doctors Niru Anne, Chelsea, Dorsey, and Burnetta Herron. And they're all highly accomplished academic surgeons today, leaders in their field, numerous recognitions, leadership roles, mentorship roles, really sort of changing their institutions where they are now. But they've also had a past where they were working in non-academic community-based settings. And oftentimes when, surgeons find themselves in community practice and feel a desire for a change, the big looming question is, am I trapped because of this decision? What steps can I take? And so I'm hoping that today's discussion can illuminate for the audience the various ways in which someone, even if they have a vibrant career that's right for them at one point, in one setting, if they are seeking the next setting and wanting for it to be an academic environment, what can we learn from our speakers and how can we set ourselves up for success? I, of course, did the opposite. And for me, I was at a stage where being in, community practice right now is exactly where I need to be. And so really looking forward to this discussion. And rather than reading off your bios in a rather, unfamiliar way, I wanted to start by asking each of you to tell us where you work now, some of the things you're doing sort of in the context of academia, research, education, leadership, mentorship, hospital level, quality leadership, whatever those roles are that you've taken on in academia, but then also tell us where you were before that when you were in community practice. I will start with you, Chelsea.
Hi. Well, first of all, thank you so much for having us. I'm excited about the discussion. So just to give a little background about me, so I am a vascular surgeon at the University of Chicago, and I've been here since 2016. But before coming here, I was out in the community, the suburbs of Chicago, in a community practice setting for a couple of years. So just quickly, my background, I went to University of Chicago for medical school, then Stanford for my surgical training, and then was out in community practice and found myself at University of Chicago. I currently, just like many folks in academia, hold a number of different hats, and probably the first to kind of talk about is I'm Associate Dean for Medical Student Academic Advising and Advancement at the Pritzker School of Medicine, and then I am also Senior Vice Chair of Faculty and Educational Affairs in our Department of Surgery, and Director of our vein clinic, and recently just stepped down from my ambulatory medical director role. So lots of different exciting things to do in academia, and I'm excited to hear about the other panelists and what they do.
Yeah, let's go on to Burnetta.
Hi, thanks so much. I'm excited to be here today. So I'm a general surgeon. I practice at Sinai Chicago. I'm also the director of surgical health equity and community health integration at Sinai Chicago, and I work closely with Sinai Urban Health Institute on health equity matters for a vulnerable patient population. Been at Sinai for just over 2.5 years, and before that I was in private practice for over 15 years in the Chicagoland area, just doing bread and butter general surgery. And I guess I can say that life events and curiosity took me to this next opportunity, which has really been phenomenally rewarding. And I'm excited to share more about that because I think it will be very insightful and helpful for others in this situation.
And then finally, Niru.
Hi, I'm Niru Anne. I'm an associate professor at Penn State Health, Milton S. Hershey Medical Center. I was in a community hospital setting for over a dozen years in upstate New York prior to this role. And I was also in private practice prior to that. So having worked in the community was a very different style of medicine in terms of transitioning. I've been with Hershey for since the beginning of this year. I serve on several national committees. I'm part of the Women in Surgery Committee. I chair their subcommittee, the mentorship committee. In addition, I serve on the ASCO guidelines for the early stage breast cancer management. I'm surgical oncology trained, so I serve on the SSO, Breast Surgical Oncology Fellowship Training Committee, as well as the Breast Imaging Technologies Committee for the American Society of Breast Surgeons. And I'm really excited to hear what Burnetta and Chelsea have to say and compare notes as what it was like to transition from the community practices to academic medicine. Thank you, Dr. Santry, for the introduction.
And thank you for the lead-in, because my first question for the group that I would like all of you to answer is, and Burnetta, you alluded to it in your introduction, but when you were in your prior role in community practice, somewhat distant, I would imagine, from the teaching of residents or students, research, those kinds of things, what were your drivers, whether it was personal, professional, what kinds of things made you feel that it was the right, time or goal to pivot to academia? And since you already sort of opened that doorway a little bit, I'll start with you, Burnetta.
Sure. Well, really, it was life. Life happenstance. To some extent, I always loved clinical private practice and doing my own cases and, the relationships you're able to develop with patients in kind of a more controlled nuclear environment. But I will say that I had reached a time where I felt that I needed more. In addition to that, I was noticing really disparate care in terms of like what I was seeing in this urban community safety net hospital setting compared to like other places I'd worked and my academic training. And I wanted to find ways to branch out and be a more substantial effort and help to kind of eradicate some of those disparate issues that I was noting in my clinical practice. But even more so, it was life. I was in the middle of a divorce. It was time to kind of find a different way. And I just started looking, and there was an opportunity that arose. And to be honest with you, I wasn't sure if it was accessible in terms of just the years of private practice that I had been. And also if it was really the fit, because I knew how much I loved to operate and do my own cases. But at the same time, I had become really confident and routine in my surgical practice, because you do get there at some point, right? Where everything's just like another case, not quite as challenging and overwhelming to some extent. And I thought that it was a good time for me to start sharing like my experience, what I've learned, and really kind of the practice pattern in private settings, and the patients that really need a different level of help to a training environment. And also I wanted to broaden my own exposure and experience to help patients who are vulnerable. And so that's really what got me where I am. It was really a blessing and has been basically like a rocket trajectory in terms of like what I found and done since I've been in my new situation, which really started as kind of a sad and scary space. And so that's why I'm really excited to like share this with others, because a lot of times we can turn really sad, scary, worrisome times into really positive things.
Yeah, that's such a, I'm looking forward to digging into that a little bit more as we go on. And how about you, Niru? What was going on? What inspired you for the pivot?
So my previous practice, when I was in the community setting, initially I was in a private practice, and subsequently the hospitals were buying all the practices, and I was hospital employed for over a dozen years. But the hospital had teaching affiliation. So I was always involved with teaching. I had medical students, and I didn't do a lot of research per se, but I did publish some case reports I really enjoyed teaching. So although it wasn't the primary hub or the training hospital or the flagship, but there were community rotations where I had learners that came and rotated with me in the operating room and in the office. And so teaching was always a thing that I really enjoyed. And the community setting worked for me when my kids were younger. And it just gave me the control in terms of how much I wanted to do, how much I wanted to, be home with my kids or take time off. It was an RVU-based production model, and that all made sense. And as life happens, like you said, during the pandemic, New York wasn't doing so well, and after the pandemic, I sort of migrated out of New York, like everybody else. And initially, when I looked at the academic practice, I wasn't sure what I was going to find or what I wouldn't find. But having worked in the community, you become very self-sufficient. You don't rely on anyone. You do everything by yourself since you just don't have that level of support. So the transition to academic medicine was actually easy because now you have lots of people who can help you with lots of things, which is very different than the community where you get all phone calls directly from the nursing staff from the floor, or the emergency department calls you directly for every single thing. And so it's been very easy in terms of transition. And I've always taught, even in the community setting. And I enjoy teaching. So I'm actually very happy that I switched or I made the transition.
Mhm. And Chelsea, what about you? You went back to your alma mater. So tell us more about what was, inspiring you to go into academia.
Yeah, so my story, I guess, is slightly different, just in the sense that academia and academic surgery was something that I was kind of drawn to really early on. I would connect it back to my experience in medical school here. And I think two things were happening in parallel. Just like all of you, I was exploring, surgery and trying to understand my interest and passion for vascular in particular. But at the same time, I was very involved as a medical student with lots of extracurricular activities and leadership roles, and that allowed me to interface with the leadership of our medical school. So even like back then, I was like, oh, I kind of like this. I kind of like being in this environment. I, for some reason, like being on these committees and doing all this stuff. So that's kind of where the seeds were planted for me. Life happens, as I think everyone has said already. My husband and I ended up doing 6 years of long distance during training. And so once we were trying to figure out where we were going to be when we were out in practice, the priority at that time was to just be together. And so we wanted to be in Chicago. And so I had to kind of be really open-minded about where I ended up, because we just wanted to be back together and be with family. The other thing I'll just add that was really, I kind of realized later, like why I like academia and academic surgery so much. I love having an impact on other people and helping people through their professional journeys. And originally, I thought that would be focused in the UME space, working with medical students. And now through these various leadership roles, I've realized it doesn't matter if it's a medical student, a trainee, or a faculty member. I like that one-on-one and talking to people and trying to figure out how they advance in their career. And that's something somewhat specific to, I think, academia. And the last thing I'll add quickly is that I like the day-to-day variety in academic surgery. I think I'd get bored if my day-to-day and my week-to-week was just like super, super consistent. My brain has to kind of switch into different gears, literally on like an hourly basis. I may have, a case in the OR in the morning, and then I have to transition to one-on-ones with med students, then maybe a meeting with legal at the university, and then a strategy meeting in our department. And I kind of like that. So, yeah. That's it.
Yeah, and I love the stories, and to your point, they're all very different. So sounds like for you there was an original calling that you were able to get back to
Correct.
after pivot to community that was was conducive to your personal goals at that time when you
Correct.
finished training. Yeah. So for people that are in that position, they've been in community practice for a period of time, and they have the goal of getting into academic practice. What tips do you have for people to position themselves well? And I would say here, get very specific. Like, should you start pre-positioning yourself, a year and a half in advance, longer than that? Do you need to cultivate informal relationships, or just go ahead and apply for that job that you see at, university of such and such? Let's go back to you, Chelsea, as a start. And comment please on, if it's any different, in terms of maintaining those connections, if you have them locally with where you trained.
Yeah, so my specific example, certainly it helped that I went to medical school here, and a lot of the same people that I had interacted with were here when I was applying for a job, and I used those connections absolutely. I would say, so just as advice, I would say, maintain those connections that you have with people that you trained with, or if you were at other institutions before. You never know when those relationships will come into play, or those connections that you've made in the past. I would say one thing that may be really helpful, and Niru was kind of talking a little bit about how involved she's been in like national organizations. I think that's one really good way if you're like starting to think that you might move down that pathway, because you'll meet so many different folks. You'll get a sense of what jobs are available. And then your engagement in those organizations, if you sit on committees, you have leadership roles in those organizations, I think allows you to, be a standout and allows people to see you kind of in that pseudo academic environment. So I'd say the networking piece is kind of key to starting to think about going elsewhere.
Okay. So, Niru, clearly, whether it was intentional or not, you were taking some steps that Chelsea would recommend. Two questions for you then. One question is when you're in a private practice or community practice setting, how do you actually get that time to go and be a part of all of those opportunities that allow you to, grow your network, have academic contacts who might then in the future want to hire you? So that's one sort of very practical question. I know that my, friends and colleagues in community practice often are just, all day, every day, not a lot of time to even get the CME done, which is required, and then to get to extracurricular stuff as a busy practicing surgeon. So how do you fit that in? And then of course, any other tips or advice that you have for people who are, thinking I'm at a point in my career where I might want to go back to academia. What can they do to prepare themselves?
Sure. As Chelsea was saying, I think contacts are the most important thing. Even when I was in private practice, when I first came out, I just maintained the contacts that I had from my training. Not just, attending the society meetings, but I think being involved in multiple organizations like American College of Surgeons, and if you're, trained in colorectal or surgical oncology, staying in touch with the national organization is very important. Not just attending the meetings for learning CME, but also more so for networking. In terms of private practice and or community setting, you're right. It's all RVU based. So you're on a go to see all the patients and operate, and it gets quite busy. But I think, if you enjoy teaching and you want to keep your options open in terms of whether you're going to switch from community setting to academic medicine or research or anything else what life might bring, from the beginning, it's best to stay involved with the national societies and make time for them. And the way the committees work is that you start working on one guidelines panel and then you get invited to do some other guidelines panel. And as much as it's a lot of work, it's more important to keep that going. Otherwise, then you're just, you're just kind of not, keeping all your opportunities or options open. But at the same time, when you're working on a lot of these things, you learn a lot. So, when you have people that you're teaching, you have to clearly have the knowledge base to teach them. So it also kind of forces you to learn and to be inquisitive and always, it's not all just about contacts and networking, but that's also, a pertinent thing is that you learn and you grow as you work on these things. But I do acknowledge it's not easy to dedicate the time, but initially on, I started dedicating the time, and as more and more organizations, and I got involved in multiple different organizations, then I just made it a mission to make sure that I completed what I needed to with those. And I sincerely think that also influenced or helped me in terms of being able to pivot between or switch between community medicine to an academic practice.
Mm-hmm. And Burnetta, how about you? And maybe talk a little bit, any tips that you might have, but also if there's a longer gap and perhaps you hadn't been, not you specifically, but if someone hadn't been nationally active, what kind of advice you would have?
Well, I agree with a lot of what's already been said, but I would also say, if you feel like there might be a possibility in your career at some point you might want to transition, I do think it's important to have some tentacles into maintaining some of the activities that will be necessary to be able to present yourself in an academic setting. And so even though you are very busy in private practice and it is RVU based, it's very focused on clinical activity and surgery. And there's time, and it might actually even be rewarding time outside of that to grow your affiliation with teaching and mentorship. And that's something that when it comes down to paper and a CV, you have been doing some teaching, you have been doing some mentorship. And so when it's time to talk about that, like for instance, in an interview and present, where you stand in terms of your ability to teach others, there have been some things there. Let's face it, when you're in the middle of the night doing a case with just a scrub tech, or the first assist who's like the fifth one that came and went in your OR in the last month, you're doing a lot of teaching and instructing during that time as well that helps build you into, somebody who can share that knowledge with others. So I would say affiliating with either your own medical school or local medical schools, because they're always looking for mentors, places for people to go for sub-Is or rotations. We also had some affiliations with community-based surgery, general surgery residency programs who rotated with us for some time. And that was nice. It was a little softer. It was really just all clinical, but it was, substantial. I would also say certainly the societies and taking advantage of any opportunities through there, because it's oftentimes a phone call of somebody who knows someone. In addition, I think it's really important that, if you're interested in things like case reports, you can build a case report out of a very unique case that you see, which we see all the time in private practice. You might want to write one up from time to time just to have something that you're building. And I would also say that I do think it's important that with mentorship, that's beyond just the OR. And finally, there's another route, leadership and positions of power and knowledge based on things like quality, safety, equity. And a lot of times they like to see people come from a different setting or from a big system to help bring that knowledge and organization to a different space. So there's many different things you can do. And then you can also frame these into a way in your discussion with someone you're sitting before to potentially hire you of how that'll make you a good candidate.
And the only other thing I would add to what Burnetta was saying in terms of teaching is teaching doesn't always have to be medical students. There's most communities have nursing, nursing students and PA students, and there's also pharmacy students. All of these colleges that the entire healthcare, different fields in healthcare, apart from just medicine or being a medical student or a physician. So all these others also require instructors. And one of the things that I did was I did have nursing students from a college that was nearby. Also, we had medical students, but it's always nice to have more than just, thinking closely about just general surgery residency, because there's also residents from ED and family practice that requires surgical rotations. So obviously you're not teaching them to be a surgeon, but I think teaching them sterile technique and, teaching them how to suture is probably, minor things is probably what you want to do, but they're still residents, they're learners. And it also gives you the opportunity to teach and stay involved.
May I add one quick thing? And with the affiliations, they do offer clinical assistant professorships at different medical schools just for taking students in. So again, just something that's going to lay on your resume that will be important to just even for you to remember. You might not have thought you were doing much, but it was important because you were offering some form of your knowledge transfer to someone else. And it really matters when you start, back with residents. It makes you realize that all of those little steps, no matter who it was, really helped kind of maintain your knowledge base and flow of how to transmit knowledge to others, especially when it comes to technical things in the OR.
Sure. And one of the other things is the County Medical Society is something that you can get involved with when you're in a community. And, once you start going to all the meetings and stuff, you can run for positions. And that was one of my first few leadership positions were with the County Medical Society, just running for different positions. And that opened the door where I was doing health fairs because I was the president of the County Medical Society. And then, the county, health department asked me to serve on their physician advisory board. So one thing leads to another thing. In the community, it's very easy to kind of gain leadership positions more so than in an academic medicine where you have to be there for a certain amount of time and the chair has to like you. But if you start, putting in community service and start doing things in the community, it's very easy or relatively quickly you can probably attain leadership roles, either in the County Medical Society or even the County Health Department. Although I'm not an internal medicine doc, I'm not an ID doc, we're surgeons, but they asked me to be on their health advisory board where I was overseeing the stats for STD clinics and TB clinics. And I haven't managed one of those patients since medical school, but literally manage or look at them, but they're just stats you're looking at to make sure if the patients are having adequate care, if everybody's getting antibiotics, they have follow-ups, that kind of stuff, but which any of us can do, any physician can, but it's not related directly to surgery, but it was a leadership role that I held for several years. And it, like Burnetta was saying, it does build your CV.
Okay,
And
so I'm
you're
hearing that, networking, super important. Leveraging other opportunities through committee work, community health work, to have demonstrated leadership skills that are often desirable for academic positions. When you first arrived, Burnetta, at your academic job, can you tell us about some of the challenges you might have faced, sort of, the first 90 days? What does that look like? Is it culture shock? What's the experience like?
Well, I'll probably give you a little different perspective on that. So my challenge began before I even walked in the door. So despite years of independent, successful practice, I was quietly labeled as the diversity hire before I even walked in the door. And of course, that designation carried like an unspoken assumption about my skills and background and just place in the academic hierarchy. So, that was tough to find out, and so to some extent, there's, I think us as women in surgery, women of color, we often have to start in a place where we have to build and earn our place and respect, but it had been a long time since I had to do that because I had been in practice and successful for so long. And so I found that the best way to just do that is kind of what we do: quiet consistency, showing up, doing excellent work, letting my actions speak for themselves, of course, holding my head high and shoulders back, even when there might have been conversations behind closed doors. But I knew that my work would speak for itself. I found that being in the OR with trainees was really very natural. And even though it'd been a while since I've been in residency, it just felt right back in the same place. It wasn't as difficult as I had expected to give up my cases. I really think I was just at that point where I had just done enough that, it was fine. There is a little bit of a challenge of figuring out a way to continue to keep your skills where they are while you're giving up cases all the time. That's something I'm still navigating to try to figure out the best way to do that. But I did feel like, there is a role. There is a role for me. And like my institution kind of prides itself with this high volume trauma exposure for residents, not fellows. And they did have significant exposure, but, there's often like this fast and furious pace, and it left kind of a void in terms of what I would describe as classical techniques of surgery that really are important. And so I felt like that was what I had to offer, was classical traditional training, making sure that people understood the importance of, all the nuanced techniques that make our surgery successful, and foundational. And there was a little resistance, especially from the senior residents, for that kind of thing when they're used to kind of like ripping and ramping through things. But I did feel like it was important that I gave that perspective to them. But I do think when entering a new institution, it's really important to observe, observe and experience. And you have to adapt too, right? You have to adapt. And do that in a respectful yet impactful way. And I think that's, really important. So I think just shifting kind of your own mental narrative, knowing kind of what to expect just in terms of being new and coming from a community environment. I always felt that it was a bit of an enigma that people felt that when we come from community practice, we were somehow less than. When you consider being in the middle of the night with these abdominal catastrophes, like literally you and a scrub tech, not even a first assist, all the time, after many, many years of practicing like that, how could somebody from our environment potentially be less than? So there's just a lot of, I think, stigma to some extent with community practice and a lack of understanding and appreciation for what we do. And they'll learn because one day that'll be them, but hopefully they'll be even more prepared from the perspective that we were able to give them. And I do think there's just a lot of value in what we have to give them. And I've actually been very appreciative of like everything that I have gained, in terms of being back in a more academic setting and being around people doing things, differently and more, on avant-garde. Is that the word for it? And so it's been really a wonderful thing, but certainly a road.
And how about you, Chelsea? What was that transition like when you came back to the academic center? Certainly, these roles in the medical school and in faculty development and in departmental operations, were, right there at day one. There must have been some navigating that you had to do.
Definitely. I was going to say, you're like, how was the 90-day transition? It was like a couple of years, honestly, until I felt like I was on my feet in academia. I was honestly like on the struggle bus a little bit the first few years, trying to figure out what my path was going to be. I think I didn't have a long list of mentors initially. I didn't realize how important that was going to be, specifically in academic surgery, and I feel like I didn't. Really hit my stride until I had those people in place. At one point, I did kind of I call it a mentor like speed dating situation where I was like, I need to find support structures here, and I ended up setting up literally like 10 to 15 meetings with different faculty, some within my department and some totally outside of my department, people who had just similar academic interest. And then I found a bunch of people that I ended up really maintaining those relationships, and they've been helpful for me throughout my career. The other thing that was really a game changer for me is I used a coach a couple years in, and I think coaches can be incredibly helpful as you transition. I wish I had done that, in the first year or so that I had started. They helped me significantly, I think, with my communication skills, and I think in the end, just my confidence being in that environment, it was incredibly helpful. And the last thing I'll say is the other thing that was helpful for me is not being afraid to be really direct with my leaders and tell them what I wanted to do and what I was interested in. And in some cases, suggesting roles and like saying, we need this. I think this is an area of opportunity for us, whether it's in the med school or the department, and not being able to, and not being afraid to say that and say that I'm willing to step up in those roles.
Yeah. And Niru, what about you? What was that transition like?
So, yeah, my transition was actually easy for me in terms of the clinical care, because it felt like I was no longer getting the first calls of, from the floor or the ED or any of those things, because someone else is getting the calls. And usually when I get a call from the resident, everything's solved and they have a plan, and I just say, okay, and seldom have to really react. So that was very nice, very easy. The part that was a little bit of a challenge was getting used to turnover times in an academic hospital. The OR turnover times are horrendous. They take forever, as opposed to the community setting or the private practice even. Because in the community hospital or private practice, by the time the first patient's wheeled out into the PACU, and then you consent the next patient and talk to the previous patient's family, the next patient's already getting anesthesia. They're on the table. So like the order of you coming into the PACU, the nurse is like, consent the next patient or mark the next patient before you do anything else. So they were like, whereas in the academic setting, it's like an hour and 45 minutes to an hour between cases, where you're just not used to it. It's a different culture or different beat in terms of the way things go. And I guess I struggled with getting used to anesthesia residents, and because it takes much longer with the PEC blocks and everything. All the blocks take so much longer. So I struggled with that, because an hour turnover plus then another hour for anesthesia to get settled. So then you're just like, I'm just pacing in the room. So I'm not used to that. I think it's just in terms of transitioning, otherwise, I do acknowledge what you guys said. There are definitely gender roles. There's definitely expectations, or, there's some sort of a myth about community surgeons, or, some sort of a aura about them not being equivalent to academic surgeons, which I don't think is true in any way or format. Because I'm the same physician I was in the community here. I don't take care of my patients any differently than I used to. And I think in terms of technique, like Burnetta said, you're self-relying in the community. You have to do everything on your own, from the Foley catheter all the way to the operation. So you just really don't have that kind of support. So I don't think it makes you any less of a physician than any other academic, physician or surgeon. And those of us who like to teach, whether you're in the community or in the academic setting, I think it would be the same. But yeah, I do understand what you mean. When you have chief residents coming into the cases, you have to let them do the case, skin to skin. So that's a little different watching someone else operate. That definitely is very different.
So adapting to changes in efficiency, changes in OR presence, combating stigma by demonstrating, excellence, and then some self-advocacy. Sounds like those are all sort of really important parts of that transition. We have lots of interest in the Q&A, so I'm going to pivot to the audience now. We talked a little bit about, setting yourself up to be able to, be considered for academic jobs. So you've applied and you've gotten an interview, and one of our audience members is asking, what were the hardest questions you got during your interviews for the academic position, and how did you respond to them? Let's start with you, Chelsea.
I'm trying to think back too. So it was a few years ago, but I don't remember feeling like I got stumped on a question, but I feel like what they're trying to do, as most folks are in interviews for any kind of position, they're trying to understand what's it going to look like to have you here at our institution, and they want to understand kind of what vision do you have for yourself. And you may not have all of that figured out at the outset, and I certainly didn't. I was just a couple years in, after training, when I was moving into academics from community practice, but I at least knew I had this really strong interest in medical education, and so that definitely was a theme throughout most of the interviews that I had, in trying to help them understand what roles I would be potentially interested in, and kind of what an asset I would be as far as bringing me back into the fold. But that's probably how I would respond.
Yeah. And Burnetta, how about you?
I think that you still need to have a self-awareness of kind of what your path might be, to kind of preemptively prepare to some extent. And that can be, subtle little things, getting involved in your societies and some of the committees, because it all gives you more to talk about and share and to grow from. Also, we talked before about relationships. I'm getting a little off topic, but I just wanted to mention this. Your alma mater, local medical schools, etc., they're often looking for people to help interview medical students and residents. And sometimes that leads to being asked to participate in things like mock orals and things like that. So you may not feel like you want to be hardcore involved with being and attending in a training program, but you are doing, these little bits of things around that then can lead to you being able to have that conversation when they ask, well, have you ever taught residents? And maybe that answer is no, but you have some other little pearls of things that you can bring in, which it could even include giving grand rounds or some things from time to time, or presentations. And then maybe focus that discussion about how you really enjoy teaching from the experiences that you've had with whomever they're with. And how that made you realize that this is something that you want to evolve further into. So you can use your weaknesses as positive things. And I think those are some of the harder conversations when they're looking for somebody with, a lot of publications or a lot of academic experience. But also they're looking for people that are unique. And I'll be honest with you, there are a lot of opportunities out here. People, I don't know where everyone's working or what they're doing, but there's these universities, these academic centers are looking for help and for people who are interested and have passion. And if you can portray that, that's enough.
And what about Niru? Any tough questions that you have advice for on answering?
Yeah, I do agree with both Chelsea and Burnetta. I don't recall any particular interview questions or interview being difficult or being at a loss in terms of answering the questions, but I think, like they both said, they're looking for people who are passionate about what they're doing and they want to hear from you. And so the white elephant in the room for me was I did have some case reports and case publications, and I did this work on with the committees, but I didn't have any hardcore lab or NIH grants or R1 grants, or, I didn't have any of that research background. So I mentioned that myself in the interview. I said, I love teaching, I love to operate, and I've done some of this clinical work, but I haven't really published in the hardcore sense of publishing or having this R1 grants, and those are my weaknesses. And I just put it out on the table. I said, but this is what I want to do when I come here. And I think that whole self-awareness of what your strengths and weaknesses are, and just being upfront honest, is probably the best policy, like any other relationship. And the interview should be, like she said, smooth. I mean, when you know what your strengths and weaknesses are, no one's sitting there and picking at your resume. I hardly feel that's the goal.
Yeah.
I was just going to add, like any interview, like do your homework too. I think one way you can kind of make yourself stand out is by really understanding kind of the different opportunities specific to that institution. So like me, I'm just thinking back, me, for instance, I knew that University of Chicago had a medical education fellowship. And so I knew the ins and outs of that. And I knew that if I came there, I wanted to participate in that, and learning about the different programs or leadership programs that you potentially want to participate in. Again, trying to help them understand what the vision is of you there at that institution and what you're going to be doing on a day-to-day basis.
I agree. Can I add one thing? I'm sorry. I'm sorry.
Yeah, sure.
Time, but I really wanted to reemphasize something that Chelsea mentioned. Like, really try your best to not get stumped by questions about what you do or don't do. In particular, how often do you do advanced hepatobiliary surgery? Well, how often does anybody, like, who's a generalist, right? You want to reframe those questions into, you can listen and answer respectfully, but you want to reframe that into, like, well, this is what I do, and like show your strengths of what you do and help create in their mind. Because sometimes you can see the wheels churning of, like, some little niche that you want to grow, that you want to develop, that may not be named yet. Like Chelsea said, like, you're developing a space and a niche for yourself. And sometimes that's even evolving as you're having the conversation in your own mind. But just try your best to not feel shut down or disappointed or excluded by some of those conversations, because they will try really hard to some extent if they are not interested in, your package, but you can reframe it.
I wish someone had taught me when I went in the other direction how I can operate and do like I need 4 hands operation with just the 2 hands, because they surely don't prepare you for that if you've been in academia and have always had, a chief resident and an intern in your OR for like 15 years. So the question that is in the chat, though, for you is the other end of that, which is, some of you had residents and have lots of experience teaching, but if you haven't, are there resources when you're, getting into the OR again with learners to whom you have to give, this sort of graded autonomy? What kind of resources are there for you as new faculty to be able to develop that skill? I'll leave that for anyone who wants to answer.
Well, I know at our institution, there's lots of opportunities for faculty development, specifically around teaching. So there's asynchronous options. So if you just want to watch a lecture on giving feedback, on writing good evaluations, on, a laundry list of things, using EPAs, you can do that in your own time. Usually within departments, there's also an educational curriculum there. So on a quarterly basis is what we do here. There's usually some teaching to the faculty members around a specific topic. So it's a combination of things that are integrated in the day-to-day to the department, to also looking for those things and being really intentional about it if you know that those are areas of weakness for you.
And before you get there, the ACS offers tons of, pathways for improving resident education, opportunities, workshops, those core lectures you can do at the meetings and even outside of that, as does the ACGME. And there's a lot of pearls from the ABS. And so again, an opportunity for you, if you haven't had residents or students in a while, is to have done a few of those. And then when you talk about it at your interview, you highlight, like, I recognize it's been some time since I had, I trained someone. And so I've done these particular courses to help kind of, bolster like my knowledge base and skill with that.
Yeah, and that
I was
really
going to add, we actually, oh, I'm sorry.
Oh, go ahead.
I was just going to add, we actually have a consulting service here too, kind of med ed experts who will come and watch you in whatever environment you'd like them to observe you, whether that's in the OR, on rounds, in clinic, watch you actually teaching, and then they'll give you feedback. So I'm sure other institutions have similar resources.
Yeah, most institutions have the faculty development seminars, lectures, and I've seen those here at Penn State as well. And there's also faculty leadership seminars and programs that facilitate with that. Yeah. But I think in the OR practically, I just tell myself when I'm walking in, I need to slow down because I don't, I think when you slow down, then you're more patient with the learners and also less likely for them to make mistakes. And I let them set the pace in the room so that I'm not just walking in my usual pace.
There's an interesting, one of the audience members sort of combined 4 questions into one. So I'm going to try to tease them out a little bit about teaching. What advice do you have for surgeons who are in private practice to having residents in the hospital? Is there anything different than what we've already talked about? Any sort of pro tips? And how do you relate that then to a transition from an RVU-based practice to, an academic practice? Or is that even a thing that you think about? Or is that you just sort of like walk in the door knowing that your compensation structure is different and teaching is part of what you do?
I knew that right away because I took a pay cut. That is something people should definitely think about as they're going from community practice to academics. That won't always be the case, but I think it's something important to think about.
Well, it's really good that you're preemptively thinking about that because RVUs don't always go away in academia at all. And you're right. I mean, you're giving up your cases. They take 2 to 3 times longer. Maybe you be smart and kind of like take hold of part of the case and not give the whole thing up so that you can kind of keep your volume and timing appropriate. But one thing I will say is when you're negotiating contracts, it is the absolute best and pretty much only time where you have a real voice. And so I love the fact that you're already thinking about that and you can kind of mitigate things. Maybe you're going to try to change your point status so your RVU number is a little different. With some of it being leadership or some other, teaching type role so that you can capture the RVUs that that you can do. But it is true. It's I really face that a lot where I think, so do you want us to be like teaching, heavy clinicians churning things out? It's very difficult to do it all.
And so the follow-up question from the, same questioner was, did you have to negotiate protected time, APP support staff, so that you can, spend time teaching residents? And so my thought on that from the moderator perspective is there's a lot of things you can negotiate when you're taking on your, academic role. And that sort of depends on, what your interests are, whether it's an equity leadership role, more focused on teaching, maybe you did want to get into research and you wanted a little bit of time to sort of focus on getting those hardcore publications and getting some grant funding, right? So there's all that stuff you can negotiate. But that time teaching residents, in my experience, in many academic centers, the time that you spend teaching in the action of patient care is often built into like a sort of automatic, your base for everybody is like a 0.9 clinical, because that 10 is the sort of 5 or 10, or, it's institution dependent, is the variable for the sort of teaching that goes on during the course of patient care. So, was there anything separate that you would negotiate specifically to teach residents when you were getting into your academic roles?
No, I was going to say for me that's kind of what I came into as well, point nine clinical, and then over time you take on different roles that have protected time, and so then that balance just changes as you have different responsibilities and different roles. I was younger when I started, so I didn't come in with all this leadership experience and all these things that I had done to be able to say I need time for this. But I was really intentional once I got there in saying trying to get different roles. So in the medical school, for instance, I started out as a career advisor, and then I was director of preclinical advising for the students, and then took on the associate dean role, and those had different levels of protection at each level. So that's kind of what it looked like for me.
What has it been like and I'd like each of you to answer this if we can in the last few minutes. What has it been like as you've taken on these other responsibilities? And there's one thing about, like, now I have learners in the OR and I've got to, seed, time holding instruments and doing the actual case. But beyond that, as you've taken on these other leadership roles or these other research roles and you've gotten that protected time, what's that experience been like when you're like literally just operating less? Like, you as a practicing surgeon are in the OR less because in the context of your academic job, you have these other roles and responsibilities. I'll go back to you, Chelsea, since you were just talking about that topic a little bit.
Sure. Yeah. So for me, my leadership, like I came in interested in medical education, but not necessarily like all these leadership things. So that came along the way. And it really wasn't until I took on, so I was vice chair for DEI in our Department of Surgery for several years. And through that kind of on the job experience, starting in 2020 in a crisis, and like really, gaining leadership skills along the way, that's where I started to understand that I just kind of really I like leadership. I'm well suited for it. And I like building programs from the ground up. I like strategizing around complex problems. I like org charts. I'm like such a nerd. Like it's really bad. But I didn't know that until I started getting in some of these roles and had some of these different responsibilities. So it's been a little bit of a journey for me.
So, but there's not that sort of yearning of, I want to be in the OR 5 days a week. I miss it so much. You've been able to, your cup has been full with a variety of different things.
Correct. Yeah. And like I said, it took me a while to realize that for me, one of the really satisfying things at work for me is that impact on the people that I'm working with, and the learners and the faculty. And so I get a lot of satisfaction out of that. It's fun to be in the OR. It's fun to work clinically. But for me, I like that other aspect as well.
Yeah. And Burnetta, how about you?
Well, I would say it's important to have boundaries, which I don't. And I really hope someone else can develop that much better than I have, because what I found is like with like I'm 0.2 admin and 0.8 clinical, like I'm still doing as much. Our views might not necessarily be where they need to be, but like you're still doing it all. And there are so many opportunities. Like, for instance, I noticed at University of Illinois, like have an academic affiliation there, like they do a lot of that buying down time, which I think is really considerate of people's life circumstances or interest of wanting to, mold their practice or mold, who they are in terms of a, mentor, teacher, whomever. And so, but you will see that it's hard to like, it's not like you just doing this that one day. And especially if you're still taking call and have patients in house and trying to maintain even a slightly tailored down practice, the lines are very blurred, and you can literally end up working all day and night, 7 days a week with all of your, presentations and admin and whatever else. So I think that it's really, again, a good thing that you're being thinking about this. but kind of try to see what you think your week could be like and look like. I think you can make the best of what is presented before you. I would try to do that mostly at the beginning. I think maybe in some institutions it's easier to kind of reframe that over time, but not everywhere. And open yourself up to opportunities, but be cautious because it can get overwhelming. Because there's a lot to do and a lot of need in a lot of these institutions for people who are interested and want to put the time in.
And then Niru, we'll let you have the final word today.
Well, the final word is I think if someone's interested in switching, they really should pursue it. But from the beginning, I think it's very important to have involvement with teaching or some sort of leadership positions, or even being involved with some of the national societies. Not just because someday you're going to switch from community practice to academic medicine, but I think it's for your own professional growth and personal growth. And when you're involved with these different things, you learn a lot, you grow, and you make connections and you network. So for all the important reasons and for your own personal and professional growth, I think it's always a good thing to get involved, whether you're in a small community setting or a private practice, or whatever the model setup is.
And missing that extra time in the OR that you might have had in private practice or a community-based role?
I think community practice was rewarding. It worked for me at that point in life. And, and I think it did prepare me well to transition to academics and enjoy my current role teaching and doing what I'm doing. But Burnetta, did you want to add something?
Oh, no, I agree with you. I just say go for it. It's worth it. You can really make it into what you want. And, if you miss operating and not doing enough operating, you talk to your chair, you do more. I think that's always, I think doing more cases and have more exposure to the OR is always accessible, but you may find that you're having a different level of growth and enjoyment in some of the other opportunities that come through the academic practice.
Yeah. And it might be that people are wired to have all of that sort of like intensity in the operating room, may not have ever even gotten to the point of considering a pivot, right? So I would imagine that the people in the audience today probably already feel that they would be somewhat comfortable, taking on these other opportunities and not, having so much time in the OR and other clinical settings. So I want to thank everybody. We are past time. This was a wonderful discussion with three very, very inspiring women surgeons, fellows of the college. And I want to thank the audience for being here today as well. Have a good night, everybody.